I'm Dr. Rahul. I'll be speaking on decision making in PCL injuries. The talk would be okay. So coming off, so I'll be talking on the following headings: mechanism of injury, clinical examination, imaging, and management, both non-operative and operative. Coming to the injury pattern, it's usually either a blow to the front of the proximal tibia, particularly when landing heavily in the front of the flex knee, particularly in sports injuries, or it could be a forced hyperextension, wherein there is a more significant injury, which means to say that there could be an associated PLC injury also, or it could be a dashboard injury. Coming to the clinical examination, what we should not miss is the PCL laxity, or if there's an associated combined posterolateral laxity. Okay, so the classical physical sign which has been mentioned is normally the anterior tibia should have a step off when compared to the distal femur. So as you can see on the picture on the right, the anterior step off is lost. This is the classical physical sign which can be checked with the posterior sag test or the Godfrey test. The top one with hip and knee in 90 degrees of flexion. So you can see compared to the opposite knee, okay, you can compare where the proximal tibia is. Okay. The other test which is normally done is a posterior drawer test. Give a posterior thrust to the proximal tibia. Check, what you need to initially check is where exactly the tibia is stationed. So you need to correct whether that step off is there or not. You need to check and then do your posterior draw test. A reverse Lashman test is another way in which we can check it out. When we are thinking in terms of a combined injury, then the dial test becomes important. Put the patient prone, knee in 90 degrees of flexion, and give an external rotation to the foot or to the lower end. So that's called as the dial test, which is positive at 30 degrees of flexion in case of a PLC injury, and positive at 30 and 90 degrees in case of a PCL plus a PLC injury. So that would help us in finding out if there's any associated posterolateral injuries. In case of a chronic PCL injury, the patient will be able to demonstrate a quadriceps active test. When you ask him to actively contract the quadriceps, the tibia which is stationed posteriorly comes forward, correcting the sag which has been present. In a few cases, with the help of stress radiographs, particularly in the kneeling position, wherein the whole of the body is giving an anterior thrust and the tibia is being pushed posteriorly, the stress radiographs can be taken. So the measurement is usually done by a line drawn along the posterior aspect of the tibia. Extended superiorly, you draw one more, mark the point at the posterior end of the Blumensaatz line, and the distance between these two is considered the side-to-side difference. If it is greater than 7 mm, we should consider it as a partial PCL tear. If it is between 8 to 11 mm, we need to consider it as an isolated complete PCL tear. If it is greater than 12 mm, it is indicative that there is a combination. It's either a PLC or a PLC or a posterior medial complex injury also. So with regards to the clinical grading, okay, so the first picture shows the normal one. Grade 1 is there is a posterior sag, but it is still in front of the distal femur. Grade 2 is the posterior sag is just obliterated. So it is at the level of the distal femur. In grade 3, it is completely posterior. Grade 1 and grade 2 are usually in case of partial tears. Grade 3 is usually a posterolateral complex plus a PCL injury. So coming to the imaging modalities, MRI is considered as the most accurate diagnostic modality, but only for acute PCL injuries where the sensitivity and specificity is nearly to the extent of 100%. It's not the case with chronic injuries. In acute tears, you can either find a focal discontinuity either at the level of where the attachment to the femur, or it could be a mid substance, or in a few cases where there is a tibial spine avulsion, you might be able to find that in the X-ray. So you will be able to find that in the MRI also, the tibial avulsion which is there, and the PCL is lax and redundant over here. So in case of a chronic tear, the PCL being extrasynovial has a very good tendency to heal. It heals, but it heals in the lax position. So you might find that the PCL is still present on an MRI, but clinically it is not functioning. So how do we find out that? In a sagittal image, if the AP diameter of the PCL is greater than 6 less than 6 is considered as normal. So greater than 7 is considered as there is probably a healed PCL which is still lax. So it's present but not functional. So coming to the management per se, the acute PCL tears, non-operative management. Indicated in cases of acutely isolated grade 1 and grade 2 injuries. In a grade 3 injury, also we can try for a non-operative management if the patient is mildly symptomatic or is a person who is doing only low demand activities. There should not be any injuries to the secondary restraints, or in cases of a non-displaced or a minimally displaced PCL avulsion fractures, a non-operative management still works. As I said earlier, PCL has an intrinsic ability to heal. This usually is accomplished in a lax position. So our main work would be to make sure that the PCL does not heal in the lax position. So with the advent of these static or the dynamic braces, which help in pushing the PCL forward, pushing the tibia forward, so there is a good tendency for it to heal in the proper position. Rehab with focus on quadriceps strengthening is very, very important, and avoiding open chain hamstring exercise or for at least up to 3 months. The bracing may have to continue for up to around 12 weeks, so approximately 3 months. Coming to the operative management, particularly in case of multi-leg injuries or displaced PCL avulsions, what we need, it is important to make sure what the patient's demands are. So if there's a PCL repair which needs to be done, it probably can be done with the help of a scorpion or something, take a bite with the PCL and fix it onto the medial femoral condyle. You can augment it with the help of suture tapes. If there's a PCL avulsion, an option of fixation with screws or a fixation with suture tapes is also, suture fiber wires and a button in front is also available. With regards to the reconstruction, we can either do a single bundle or a double bundle. There's a lot of controversy with regards to which is best. In a single bundle, the only anterolateral bundle is reconstructed, whereas in a double bundle, both the anterolateral and the posterior medial bundle, helping in near native knee kinematics and better rotational stability. So that's a flow chart. I've divided it. So if it's an acute tear, grade 1 or a grade 2 can be treated non-operatively in the initial part. If the symptoms are present, then we need to go in for a PCL reconstruction in grade 2. If it is not, then we can leave it alone. Grade 3 usually requires early PCL repair or a reconstruction. If it's a combined injury, this is where the problem arises. So if there's a vascular injury, that takes preponderance. That needs to be taken care of first. Then you might at the same time do an early PLC repair and then plan for a reconstruction at a later date. If there's a posterolateral coronary injury without a vascular injury, then probably you need to take care of the other ligaments also, the ACL and the MCL, either with bracing or a reconstruction. So coming to the decision-making in chronic PCL tears. So a PCL deficient knee, it has been found there's an increased incidence of medial side osteoarthritis and changes in the patellofemoral joint. So leading to the medial compartment OA is commonly seen, and associated increase in the meniscus injuries also. So because of the PCL injury, the posterolateral structures might also become more lax because of the excessive strain. So the patient might develop a varus thrust gait. So we need to get scanograms done to rule out any varus alignment. And in those cases, we might need to do a HTO, probably a medial open wedge HTO, to make sure that correct the posterior slope also. And thus, we may have to check later on whether PCL reconstruction is required or not at a later date. If there are any other ligament injuries, we need to reconstruct those. So the last flow chart. So if there's a chronic PCL tear with a varus alignment, we may have to do an HTO and then go in for a PCL reconstruction. With an isolated PCL tear with minimal arthrosis, then again go in for a PCL tear after a period of rehab. Combined injuries, if there is combined injury, rehab him first. Arthrosis is mild. Reconstruct all the ligaments unless there is a contraindication. So to conclude, non-operative management has picked up particularly for the PCL with the bracing option being available. Nearly all grade 3 injuries and some grade 2 lesions will benefit from from PCL reconstruction. PCL reconstruction results, surgery results are pleasing, but less predictable than ACL reconstruction.